Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
So today's episode is one we've really been looking forward to doing for a long time. And it's because it touches on something that so many people experience, but often really don't feel comfortable talking about, and that is their relationship with food. So we're going to be taking an honest look at what the landscape of eating disorders looks like today and how much it's changed over the last several years. We'll talk about how social media, wellness culture, and even some of the messaging around healthy living can blur the lines between health and harm when it comes to eating. We'll go everywhere from restriction to binge eating, emotional eating, and really the importance of how GLP-1 medications and this new world of weight loss medicine is impacting how people have a relationship with food.
After this show, we really want to help you understand when to be concerned, whether it's about yourself or even just someone you love, and recognize some of those early warning signs of eating disorders, and also give you some ideas of where to turn for support. And we had to bring a specialist in, of course, and we have a phenomenal guest. Psychiatrist, Dr. Erin Knopf, an expert in eating disorders, is the founder of Very Health, a virtual practice dedicated to helping individuals heal their relationship with food and their bodies. Welcome. We're so excited to have you. And to get us started, can you just tell our listeners a little bit about yourself and what got you interested in becoming a specialist in this?
Absolutely. Thank you so much for having me. I like to describe myself as a socially acceptable nerd. I wanted to be a physician, from age 6. And fell in love with eating disorders actually accidentally. I was in undergrad and working in Dallas, Texas at the Children's Medical Center, and all of the patients on the inpatient psych unit at the time had an eating disorder. And seeing this overlap of biology and psychology and how many systems it kind of hijacked, even though it was an individual disease, if you will, it still affected family, social life, future planning even. I knew this is what I wanted to do. So when I went to med school, thought, let me be a child psychiatrist and work with kids with eating disorders. But then I found out about the triple board program. And for those that are unfamiliar, this is a combo pediatric medicine, adult psychiatry, and child psychiatry residency. And I thought, oh, this is perfect. I can holistically treat mind, body, soul for kiddos. And that was it. My fate was sealed. And I like to joke, that was 2007, I think, when I first knew I wanted to work with eating disorders. And here we are 19 years later. So after doing my training at the University of Kentucky, I joined an incredible group of physicians at the Eating Recovery Center in Denver, Colorado, and served as a unit psychiatrist there. Worked at the only eating disorder ICU in the country, acute health at Denver Health. And I was there during the pandemic. So you can imagine that was a thing.
I bet. Yeah.
I was the only psychiatrist there for a 30-bed unit. And I'll admit, between COVID and having 2 babies, I really burnt out. So that's how Very came to exist. My husband is a business attorney. That's really useful to have, by the way, when you're going to have a startup.
Pocket.
It was one of those. It was actually his idea. And I absolutely said, are you kidding me? I did not go into medicine to be an entrepreneur, but I guess I can call myself that now. So we started very. We really wanted to close that gap and bring expert clinicians that really people could only access at higher level of care to the outpatient everyday care. So all of my clinicians are career clinicians working with eating disorders, and we serve patients 10 and up virtually for psychiatry, therapy, dietary services across a lot of states now, but we say mainly 10, but you can check our website for more. We can offer almost two services actually in 42 states nowadays. Wild. Gives me the goosebumps.
That's incredible.
Thank you. Thank you. Blood, sweat, tears, I swear. But what's cool is we are here to collaborate with community providers. We are not looking to take someone away from one of the supports they have, especially if they're in an area where they did find an eating disorder informed provider. That's perfect. We just want to complement and fill out that multidisciplinary team. So we work really closely with other community clinicians and building that community together because this work is hard. It's really hard to do. And the only way through it is together, truly.
Well, let's get started on some of our questions.
Yes. When we talk about eating disorders, it's such a broad thing and it can be from one side to the other, either not eating enough or eating too much. I guess, what do you just wish the general person understood about eating disorders in general?
Oh my goodness. One, I think the first thing is to understand who is affected by an eating disorder. It used to be seen as something only happening in white, cis, het, affluent females, but really that was a skewed data point or statistic. That was just who was getting care. So, really, eating disorders don't discriminate. They exist in all cultural backgrounds and across socioeconomic levels. They affect men, they affect women, they really affect the LGBTQ community. And if anything, eating disorders cannot be diagnosed with your eyeballs alone. Actually, only 6% of people with an eating disorder are classified as underweight if we are using the BMI scale.
I know that that is something that so many people even have a hard time understanding they have a problem because that's what's been
Mhm.
communicated to them. Not just healthcare
Yeah.
professionals identifying about individuals like, there's no way I can have an eating disorder because I have a normal weight or I'm overweight.
Mhm.
We've really just made it only about a number on a scale, trying to think about it that day.
I love how you mentioned that because it really isn't part of the criteria to have it be part of or a scale number. It is behaviors, thought, feelings, and beliefs. That is what makes this a mental health diagnosis. I think it is more complicated by the fact that it has so many biological and physiological complications that follow. But this is something that more often I think people are struggling with, and even specialists don't know to look for it. I mean, we talk about constipation, in a GI clinic, people think, oh, no big deal, or maybe this is just IBS, IBD related. But constipation from slowed gut motility from intentional weight loss is almost ubiquitous across the board. Anyone who is dieting and yo-yoing through caloric restriction, caloric excess is going to have slowed gut motility with constipation. So that's just one example of, the chief complaint may not be weight loss in clinic if you're a general practitioner. It could be a lot of other things.
Let's start on one at the end on the spectrum.
Why don't we start with overeating? Or can we start with like binge eating and emotional eating? What are
Yes.
these and what are the differences between them?
I think there's a difference between clinical language, in the diagnostic manuals, cultural language, and then when you're doing this clinical work with individuals, you see it a little differently. So, from my perspective, the root of binge eating is actually restriction. These are individuals who are trying to limit either certain types of foods, maybe it's the treats or the chips, fried food, baked goods, all the things that they're moralized to feel are bad for them, they shouldn't eat. And even if there's just mental restriction and not actual restriction, that still does something in the body. If I told you don't think about pink elephants, you're thinking about pink elephants now. There's no way around that. So if you tell yourself don't eat candy, all you're going to think about is candy. And even if you don't buy it, because you say, I can't have it in my house because I'll go too far, the moment you're around candy, your brain will have a scarcity mindset, will think just one piece. And then that one piece reminds you how much you love candy. And now you're thinking, just this one time, I'll have as much as I want and then never again. It becomes this feast or famine. You make promises with yourself, and you get into this cycle where now you've ended up overeating candy. You've had more than the portion. Maybe it wasn't a true binge, more than what someone else would eat, and you're having physical discomfort from it. That is possible. But it's still nonetheless that cycle of now you feel guilt and shame because you went overboard and you did ingest more than was potentially the right amount for you. So I really like to point out for people, hey, if you're having binge eating issues or night eating issues, look at what's happening before. What does the previous day look like? How have you been thinking about food options? How have you been optimizing macros as far as making sure you are getting fat, protein, carbohydrates, fiber daily? This isn't just, stock up on protein and your body is content. You do need carbohydrates. You need that glucose. It is real. I know there's a lot of debate about added sugar and whatnot. I think there's so much more nuance in individualized care that there's really no way to give one blanket rule to everybody. So, if anything, emotional eating makes sense too. You have this desire to feel comforted, and that's actually part of our wiring. It's what makes us different than animals. We're not just eating to fuel our bodies, we're eating socially, we're eating emotionally, and we don't need to demonize that. It's just a matter of knowing it's okay to seek comfort from food, but how do you teach yourself that you can always have more later, and build that abundancy mindset? The scarcity mindset, again, is what makes the risk of quantity overload, if you will, when you're eating in those scenarios. But you do not have to deprive yourself of comfort and support. You are allowed to feel soothing and relief from eating a meal you really enjoy.
I find this hard when working with patients and trying to help them develop a healthier eating behaviors and lifestyle. How do you really counsel people to learn how to decrease ultra processed foods that sometimes can almost feel addictive to you, but also not develop that scarcity mindset? It's a hard balance. So how do we do that?
I think it starts with, kind of relearning. We have to unlearn and relearn how we look at food. So processed foods, became very popular post World War II. Everyone was using these quick, Campbell's soup meals and recipes to get through the day. And it was a way of increasing productivity, but also reducing strain on, primarily women at home. It was touted in all the advertisements. So I think there's a difference between artificial ingredients when we talk about processed foods and foods that are processed. I like to point out that even bread is a processed food. We can't just eat wheat from the field. The wheat has to be ground down and filtered, and then that flour has to be used for something else. So it technically did undergo a process to be ingested so our bodies can digest it. I think there's, other information too of what makes digestion hard, perhaps, is some of these foods. If someone has an issue with processed bread, maybe it is because they need to have sourdough bread, for example, where the gluten is already broken down by the microbes that are in it. That's another thing of when we look at history, that's what most humans were eating. They weren't eating the type of bread we eat today. So I know I'm jumping around here, but there's lots of different perspectives to look at here. When it comes to the high processed foods like chips, candy, things that are always packaged on the go, I think it's more about moderation, especially if you are someone who doesn't have access to fresh fruits and vegetables regularly, or due to scheduling, you need something quick and easy. Something is still better than nothing. And it's a matter of can we still pair processed foods with other options? And so I'm thinking of, this is where I talked about the nuance, what you and I might be buying for our families and how we're structuring our meals. Or I have a 4 and a 6-year-old, and my husband and I, is different than what a single parent in a more urban environment might be forced to buy and feed their children. So I think there's just so many nuances of, hey, you do the best you can, and you empower the person to know you're still making a good choice by feeding yourself and feeding your family, and not having your kiddos go through experience of starvation. And, is there any possibility of creating more diversity here of where you get your nutrition? I think that's different. Calories, when we're talking about just general meeting of body's needs. Calories, it doesn't actually matter as much where it comes from, but ultimately the body always functions better and feels better and can manage itself better when you have your macro balance and you are giving it all of the micronutrients it needs. And these processed foods are often lacking in the micronutrients. So that's why we don't want someone to rely 100% of their meal intake through that.
Is that something if when patients are struggling with this, I know I've seen it. I know I've experienced it myself is when you are having this restrictive mindset. A lot of times, if you're not balancing your food, that's some of where those cravings go that drive the binge because you went all day and you didn't get what you needed. And your body's like, hello, please give me more
Yeah,
and kind of drive some of that cycle. And not everyone realizes necessarily that's the driver of it. Just have that, like you mentioned, that shame game that starts happening. It's like, oh, it's me, it's the willpower, I'm the problem. When truly, like you had mentioned, if you reflected earlier in your day, you're like, if I had, had not restricted all day and ate a balanced meal for breakfast and lunch, I wouldn't be here right before bed, just eating everything in sight.
exactly. And also, that anxiety, the cellular levels having from experiencing nutritional deficits during the day is also what drives insomnia and the difficulty to falling asleep and the racing thoughts. And so when people say, I get in bed, I'm trying to fall asleep, but I'm so hungry, I have to get up and go. I mean, this is where there's both a combination of consciousness and unconsciousness driving binge eating or overeating in the evening time, especially. There is a biological pull to eat. I think it's interesting, we get a little nerdy here. Everyone talks about one of the mechanisms for quote unquote obesity would be leptin resistance. So, leptin, people have heard leptin and ghrelin. These are hormones that help us monitor, maintain our hunger satiety cues. What's interesting with leptin, it's an opposite reaction or an opposite direction to hunger. So, when leptin is lower, hunger is higher. And as you are eating more regularly and consistently, leptin will kind of be in the more of a medium range. When you are binge eating, leptin can actually get quite high. And so that's supposed to tamper down your hunger cues, if you will. But in some people, it's not. If anything, when we look deeper into those cases, for example, we actually find they were always going through some sort of weight cycling where they were dieting, rebounding, dieting, rebounding, dieting, rebounding. And this is where the adaptive physiology that wanted to protect them from that starvation mode just was working in the wrong direction from what society wanted, what modern medicine wanted. They wanted the person to lose weight. The body said, why are we in famine mode? Where's the lack of resources coming from? I don't know. And it just changes the entire processing of the brain. But if you do that long enough, we know this model exists in other forms of medicine. If you're not listening to the internal neuroendocrine cues, your body stops responding. It's like, well, never mind. There's no point.
Mm.
This isn't what we do. Other things happen. So, yes, leptin resistance may be part of the issue, but really, again, who caused the issue? And especially when you're talking to people who were big kids and put on weight loss diets and pursuits from a very young age. I could get into that too. I have a whole soapbox, I'll admit, as a pediatrician of, oh my gosh, we never should have started trying to shrink kids' bodies. We are messing with their development way too much and setting them up for a lifetime of more health consequences and potentially eating disorders. But I'll put that just a pin in that for now.
So I've had patients that they've had this experience. They've had the yo-yo dieting experience since they were a teenager and they are come to you as an adult and in their 30s or 40s and they're just like, this is always the way I've been, but I always feel hungry no matter what I do. Is there a way for them to actually improve their leptin sensitivity again? Or is that something that is likely going to be a struggle for lifelong at that point?
I think when you take the emotional healing on first, then, especially if it's an older human with a developed frontal lobe, that's when you can start integrating that frontal lobe executive functioning, deeper understanding to quiet the amygdala and the deeper brain that is our survival brain, right? That when you have that integration, then someone can learn through lived experience that they can trust themselves around food, they can trust their bodies. I think what's so hard is we have pathologized body size and body weight, rather than recognizing we have body diversity for a reason. Not everyone's the same height, not everyone is the same shoe size. And yet we try to confine weight to be in this very small range that, again, is defined by an equation. Everyone's using BMI. I mean, in our training years is when it really got implemented that you couldn't even bill and have your reimbursement from an insurance company unless you marked something about BMI. So this was forced onto physicians for the last, can we say 2 decades? I'll say 2 decades.
Mhm.
Maybe it's more like one, but it's been a while. But this was arbitrary. At the end of the day, we have a mixing pot of humans in the United States, especially, but not everyone comes from the same genetic background. And size diversity mattered and was necessary depending on cultural background. There's also epigenetics. So we know that trauma experienced in one generation can still show up in the development of someone many generations later. And that trend absolutely has been seen where a generation that experienced extreme starvation 2 generations later, they are insatiable. So again, that may not be a leptin mechanism in this case. It could be something different altogether. It's just complicated. If this was a Facebook status back in the day, that's what we would say. And I think what's so hard is we see population health information and guidance given that really overly harms the individual. So this is where it really comes down to what someone's weight is and their health assessment is really between that person and their physician who hopefully is, looking at so much more than just the scale number and the BMI. What are your thoughts and beliefs around food? How do you move your body? How do you keep your sleep consistent? We know that inconsistent sleep increases cortisol. High cortisol, what does that do to the body? It causes weight gain. So we oversimplify our recommendations based off of population level information, and it potentially misses what's going on for that person in the context of their life.
And so for someone that's struggled with this and maybe BMI is not the best thing for them to monitor, what do you recommend they use as a metric to kind of see how they're doing?
And I would like to hear
Yeah.
your perspective on that from like a child versus an adult as well.
So, weight inclusive medicine is not brand new. It's been around for a while, but some of the more objective metrics, because again, we are all socially acceptable nerds in the medical field. I mean, truly, to some degree, we want something concrete we can rely on. We want to see progress or at least sustaining a new norm. I would say, again, it's more of feel and function. Are you able to be in your life? Do you feel strong? Are you working on skeletal muscle development? Because actually, there's a lot more to that than a weight number as far as someone's health and well being. Are you feeding yourself regularly? Are you making sure your body is never deprived? Some people really do need to eat every 3 hours, 4 hours to not experience a big dip. Our hunger cues, you're not supposed to wait till you're starving to go eat something, much like you don't wait till you're super thirsty to drink water. That's a sign you're already dehydrated. The same thing. When you say, I'm starving, I've never been this hungry before, that's not the normal cue to go eat. Lower or softer cues for hunger can actually be bad breath, a little bit of nausea. Some people misinterpret that and then they feel like they can't eat. But any pregnant woman could tell you, well, if I ate when I was nauseous, then the nausea went away. It's a similar mechanism, y'all, for everybody. If you notice nausea and it may be a mealtime, don't wait. Go ahead and go eat something. So, other things to look at when you're trying to help with health position is really actually make it individually focused. What are your health goals? I think this is one thing we all in medicine, because we value health, we kind of assume everyone values health. We also want to make sure that people don't get unhealthy and then overuse the system. There's all of these concerns of later stage issues. It's not that we want to impose values on someone else, but we know that if they do get unwell, they're going to show up to hospitals. And you know what I mean? Like we're trying to interrupt that. We can admit that that's also a motivation of ours. But at the same time, not everybody's health has to look the same. So, labs I think are great. It's very important to look at labs and even important too to better understand mechanisms. We talk about visceral fat. Well, visceral fat is not this terrible thing. All of the organs need to have a protective fat layer. And there's a lot to be said about why fat will show up in certain places that we don't know the answer to yet. That's the other thing. As physicians, we are giving advice and guidance on things that are is so complicated, and we've only begun to scratch the surface of the mechanisms at play. So it's where we really have to be honest of, don't know, why you might have this finding. And let's just do things that are easier to obtain. It is easier to give recommendations on moving more, improving the nutritional balance and consistency of your daily intake, and also making sure you're caring for your soul, because the social determinants of health and the domains of health matter here. Your emotional health is as important as your physical health because the two are related. The same wiring is there for both. We just don't really know how to follow the processes of the nervous tissue from a gross anatomy perspective to an emotional perspective yet, right? And how it's all wired together. We know about the gut brain connection, and yet we can't map it always, and we can't intervene exactly the same way because we don't have the ability to. So I think it's a matter of just taking in a lot more than just, okay, I see your weight. It's too high for your age and sex. And now we have to treat that. No, no. Let's look at the context too. If someone was always 95th percentile, they're going to be 95th percentile. The 50th percentile is not the gold standard. That's just the middle. Not even a mean, an average, or a mode. The most people are at the 50th percentile. No, that's just the middle. If you had 100 people and you line them up in weight order, that's 50th. You know what I mean? But for some reason, I think that got a little confused, is what I see when I talk to other physicians. They think, oh, well, I thought I needed to weight restore them to the 50th percentile if they're coming up. Or I thought I needed to have them lose weight to the 50th percentile. But, oh, no, no, no. That's not their body. That's someone else's body. And that's one of the important things to remember.
Yeah, I'm glad you brought that up because I do find that it's very challenging because for kids specifically, there's not a lot of labs. Many times when you are going for your well child checks with your children, you don't have as much data. Sometimes we, as adult doctors, receive, and you only have these growth charts, as you just mentioned.
Yeah.
And so for our listeners, if we have parents listening, and maybe this is a discussion that they've had with their pediatrician, what are some pieces of advice on how parents can try to advocate as well as take information in from healthcare providers to truly feel like they're doing what's best for their kid?
I think it's knowing that, yes, historically, we would recommend weight loss to children. The truth is, that's not the best mechanism, truly. I like to use the metaphor, kids are a ball of Play Doh, and you have to roll it into a ball before you can roll it out to a snake. So kids are always going to have a period of chubbiness, of looking bigger. And again, we can talk about extreme cases and I'll get there, but I'm talking about the average kid's experience. And too often people say, well, let's take away some of that Play-Doh. It's too much. Well, then when you try to roll it out, you're not going to get the same length snake at this point because you've removed some of the building blocks, if you will, for growth. When a child's weight is impacted, the protective evolution based mechanism of starvation mode puts development on hold. This is why kids look so much younger when they've had a restrictive eating disorder. But it's also the same for kids that have been forced to go on a weight loss diet. It delays how they progress through puberty. It can cause height suppression that's permanent. It's not benign, is what I want to say. We talk about weight loss as if it's a benign process or benign recommendation. Absolutely not for any age individual, but especially the kiddos. If anything, what advice do I have? It's a matter of first, don't focus on the weight and body size and body shape. If anything, it's time to really use language like you can say fat because there's thin and fat. We don't need to have the word fat be so, don't say that. Don't say that. That's insulting. We need to take back the fact that this is just a descriptor word. Some kids are tall, some kids are short, some kids are round, some kids are really skinny. Everyone has their own trajectory for development. And I mean, you look at a room full of 14-year-olds nowadays, it is insane. Some of them look like they are 17-year-old college students almost, and the others are prepubescent and they are teeny tiny little humans. There's no way to compare. They all have their own time frame of when they will go through puberty, when they will reach their full adult development, which is usually not until college. And the last thing we want to do is mess with their biological signaling internally. So rather than focusing on weight loss, look at again additive options. So, like, again, moving more, getting outside more. How are they doing emotionally? What's their background? I mean, there might be trauma there and a lot more to unfold than just treating a weight number and a body size, pathologizing that. It has to be holistic. And, if anything, teaching self love starts there. When we tell a kid there's something wrong with their body, they are too concrete of thinkers to take that just as a superficial thing. It becomes everything to them about their worth and their well being, and it reinforces the discrimination they experience at school. I mean, kids are mean these days and they don't mean to be, but they're learning, right? They still don't know necessarily how to treat other people that are different from them. So all they know is different. Is that okay? I'm going to start off kind of skeptical, and that might lead to some indifference at a low level or downright, in your face, like, why are you like this? You know what I mean? And that feels personal. That feels like a personal choice to be different for these kiddos when it's not. It's genetics, it's environment, it's again epigenetics too. There's so many layers there. So I'm sorry if I'm kind of going all over the place here, but it is overall complicated. And if anything, we know that weight stigma and discrimination for being in a larger body is harmful. Just period. It's harmful. And if anything, it's really no different than racism. You're talking about a snap implicit judgment of someone just from a physical characteristic. In this case, it's not skin color, it's body size. And there's this assumption of you did this yourself, you must be lazy, fat, because you don't take care of yourself, you don't value yourself, when that couldn't be farther from the truth, truly. And it's interesting how weight stigma is even in the medical field. I'm so grateful for organizations like Medical Students for Size Inclusivity and the Association for Weight Inclusive Medicine and Weight and Size Inclusive Medicine, because it's providing educational content for students, who are in medical school or pre-medical school, and then residents as well as seasoned clinicians of how do we unlearn this assumption. I mean, we were taught to walk into a room and try to diagnose someone with their eyeballs automatically, and it was oversimplified and honestly dehumanizing for the person in the room. So there's lots of layers there. So again, to your question of for the parents listening, just know that your physician has good intentions. Like to give the benefit of the doubt to all of my physician colleagues out there that you went into this because you care. And that's why you're giving health care specifically. And it's a matter of just leaning in more to the emotionality, but this is where we have systems working against us. You don't have to connect and really get under the surface sometimes in your well child checks, in your annual visits. And that's unfortunate, So if anything, I have a lot more wishes for improving the overall system of how we provide care and meet patients where they are. But at a minimum, just again, if someone tells you your kid needs to lose weight, you can say, thank you for caring. And I will have some follow up questions and comments for you later. But in the meantime, let's not talk about weight like that in front of my child. They are growing on their own trajectory.
And I think what I'm hearing from you too is that instead of focusing on outcomes and metrics and specific numbers, really focusing on consistency with certain behaviors would be the best thing. And that's something that we really just do not get trained on in medical school or residency is behavior and being consistent with healthy behaviors. But really, that makes sense. If you're consistently exercising your body and consistently doing things to improve your mental health and consistently eating nutritious food, in general, that will likely lead to health as opposed to,
Yes,
just worrying about what that number on the scale is or your waist or, those other specific metrics.
exactly.
Okay, so we're bringing up all these things and these concerns about how interactions can happen in healthcare because we're worried about triggering an eating disorder. And when we say the word eating disorder, honestly, the majority of people automatically think of anorexia. So
Totally.
let's talk about that one first, that diagnosis. What are some of those things that are happening to patients that are fueling that diagnosis and are things that we can do better to help protect our children?
So again, thinking about it's thoughts, feelings, behaviors are what make a diagnostic, criteria met. In this case, it's fear of weight gain, true fear. Like they cannot do anything else if there is even a potential of weight gain. The desire to be thinner. So always thinking, even if they have a weight goal of one number, that's not going to be the end. They will continue to push that goal further and further down. And then, of course, the fact that it causes dysfunction in their life. In the DSM, anorexia nervosa is distinguished from atypical, I'm quoting that, anorexia, which is under the other specified feeding and eating disorders. There's actually no difference between them, except in this case, weight stigma between the two. One, someone is underweight from where they should be and they are lower than the BMI 18. The other group, they're still in normal body weight, but that doesn't mean they're at the right weight for themselves. They actually have the same medical complications and the same potential devastating outcomes as far as what happens to the body in starvation mode. So I always like to remind people some statistics of, there's like 50% of the people in the country are trying to lose weight at any one time, maybe even 60%. 35% of people who pursue intentional weight loss will develop disordered eating or pathological dieting, which means they do overly think about time wise, when am I eating? What am I eating? What am I doing to compensate for my food? Can I eat with this person? Am I clean eating? I mean, even when we get into, there's this formalized term, but we all use it in the field called orthorexia. That's the over obsession with the quality of food. Are these pure, whole food, clean eating, etc. If someone's whole life is around that and it's leading to interference with how they socialize, how they plan their day, the time their brain is spending on food, that's disordered, truly. Of the pathological dieting or disordered eating, 20 to 25% of those individuals will progress to a full diagnostic or diagnostically pathology in the eating disorder world. And that has more to do with a biological click in the brain. We don't know why some people have it in this paradoxical way. It's opposite what you think. You think if the body was experiencing starvation, it would want to remedy that by asking the individual to eat more. But there are certain individuals with certain neurowiring, usually the perfectionistic, high achieving, anxious, successful. Let's be honest, they're also very successful people who are more at risk for developing anorexia nervosa because they can get really good at something really rigid and really constrained. And they feel this immense reward from it because the reward pathway got hijacked. No longer about surviving through famine, it's more of, oh, I can starve more, but they don't realize that that's what their brain is actually asking them to do. It's wild. I mean, starvation too will mask a lot of the physical symptoms that we would expect them to have it when they're starving. And patients will actually tell me that they did feel them, they just ignored it. So again, the type of GI distress they have when they're withholding food, headaches, dizziness, cold intolerance, these are things that they may not actually be feeling even when you ask them about it. But if they've lost more than 10% of their body weight in 3 months or less, they meet criteria for protein caloric malnutrition by default. And so, it doesn't take actually much to get there. What's wild is the Minnesota semi-starvation study in the 1940s was done by Ansel Keys. And he's the one who actually demonstrated just how profound intentional weight loss and starvation impacts the human being. It was only done with male participants, and they were put on an initial diet of 1,500 calories, 1,800 calories, which by today's standards sounds like a pretty average number on MyFitnessPal of what to reduce your calories to. And they were starved for a period of time until they lost 25% of their ideal body weight. And they showed all the same symptoms of someone with anorexia nervosa: food preoccupation, social isolation, withdrawal, mood dysregulation, meaning their mood was all over the place, super mercurial, poor sleep, poor sexual function, low libido, all the physical issues I mentioned before. And of course, you can get into low blood pressure, low blood glucose, low heart rate. And those are the components that we worry that someone's medical fragility is now truly medically unstable. And that's why we're looking at hospitalization when patients do have those objective findings. But again, those same things happen in the quote atypical anorexic body as well. So if someone was, I'm making these numbers up right now, 250 pounds, put on a diet of, don't eat more than 1,200, 1,500 calories to lose more than a pound a week, they're going to get to a point where they will start having physical complications if they are following through with that. And they may need to be hospitalized for hypotension or low blood pressure, bradycardia, because their body is breaking down itself in order to survive the famine it's experiencing. So that's one of those things where, yes, people think about the anorexia nervosa patients as being the cachectic, emaciated individuals, but it may not be.
We're going to pause at this moment, and I have to bring up this topic because we're seeing it today with GLP-1s.
Yeah.
Many
Yep.
patients meet exactly what you just said when they have that rapid
Hmm.
weight loss.
Yep.
What should we be doing? Because it's happening to so many people.
Yeah, and only probably going to be happening to more as we continue to prescribe these.
Y'all, it is so scary. I mean, the eating disorder professionals world has been, banging on chests and ringing bells and posting these things of like, what's happening in healthcare? This is not right. What is this? District one of the Hunger Games, oh, the only thing that matters is to be as thin, then maybe they don't play as thin as possible, but be thinner and everything will be better for your health, ignoring all of the longer term data that shows intentional weight loss isn't sustainable because adaptive physiology always takes over. Again, not a willpower thing. It's called biology. We all learned it in medicine, right? It's terrifying. I mean, they are having symptoms of, low appetite, which that's even in the criteria for depression, right? Anorexia is just the loss of appetite. It doesn't have to be anorexia nervosa, the clinical condition. But they're having this low appetite and nausea, which is an aversive experience, that helps them avoid eating and makes it hard to eat when they try to eat at normal times. And yeah, they're going without incredible amounts of nutrition subsequently. And again, the people prescribing it usually, it'd be one thing if it was just physicians, but the fact that now all these other disciplines out there are also prescribing it, in wellness clinics and spas, chiropractors can prescribe it. I mean, it's just too widely available now. You can get it on Amazon, even. You can get it anywhere. And so that means it's even more unregulated, unsupervised, undirected. And the risks with that are far and wide. But let's say we're talking about someone who is getting prescribed by someone who is monitoring. At the end of the day, what are they monitoring? They're monitoring the weight loss. Truly, they're monitoring how much weight someone has lost to get to, again, some weight number ideal that has been determined to be healthier for them. They're not paying attention to bone density. They might be checking labs, but even then, the body compensates so well doesn't necessarily mean anything. Most patients have completely normal labs when they have anorexia until they are truly medically unstable. But waiting until that point, that's not healthcare either, before you intervene nutritionally. So the goals are just all wrong. And also, when I think about, the AAP even said a GLP-1 could be used for children, I think, oh my gosh, do you not know what it's already like to be an 8-year-old in the world or a 10-year-old in the world? Now you add on nausea and difficulty eating. What kind of behavior and mood is that kiddo going to have? I mean, my 4 and 6-year-old are feral, hangry monsters when they haven't eaten enough. And if they feel even remotely unwell, oh my gosh, watch out. Like all they want to do is lay around and be held. Kids don't know how to reconcile that type of physical discomfort in the way an adult who consented to it can say, I can muster through this, I can muster through this. But also, is that again your healthcare to constantly be battling that feeling every day? I think so. And what really worries me is we know skeletal muscle loss, sarcopenia is happening in these individuals. So, what's going to happen when they are in their last quarter of life, where their body doesn't make skeletal muscle in the way it used to in their adolescent, young adult, middle aged adult lives? what's going to happen to their stability, their balance, their capacity to carry themselves? I mean, we all know that someone falling and breaking their hip in their 80s can be a death sentence. People don't often do well after that. What happens if you've now lost that muscle? How many more people are going to have mobility issues and strength issues in their 70s and 80s because of what they're doing now in their 30s to 60s? I mean, the long term issues are far and wide. Also, to go on one other soapbox with GLP-1s, we have no way of consenting them appropriately, truly. The data that's being used is looking at 5 years of long term data. Yes, we have data from Diabetes World, which GLP-1s for diabetes care, amazing. It really does phenomenal work with lowering that hemoglobin A1C and reducing all of the complications of what I like to say sugaring the organs, when someone has diabetes. Beautiful outcomes. But the weight component, looking just at weight, all studies show you will gain the weight the moment you stop this medication. Why? Because again, you're not suppressing your body's normal desire to eat and function. So, to what end? Again, in the same way that diets don't work, we're chasing the wrong holy grail here. We keep chasing smaller bodies, but that's again not health and not sustainable, and frankly, a waste of everyone's time and actually furthering their health devastation because weight cycling is what is likely causing inflammation in the body that leads to atherosclerosis, liver disease, cardiovascular issues. It is the inflammation process of the body going through different metabolic shifts so rapidly that is more damaging. And that's what a lot of other data shows, but that's not part of our daily practice in medicine either.
So, for someone who's listening and may be taking a GLP-1 right now, what is something some questions you would just have them reflect on to be like,
Yeah.
okay, this is great. I think I'm using this medication in a health safe way. Or, depending on how they're reflecting, to be like, okay, maybe I need to talk to my prescriber or find a more involved provider to help me make sure I'm not using this as something that's setting me up for a brand new problem.
I think you touch on something really beautiful that is also important for all of us physicians. It's agency and autonomy. So there's again real truth to wanting to escape weight discrimination. It makes sense. People always talk about, man, I get treated better when I'm in a smaller body. I feel more beautiful. I can date again. I mean, there's so many layers there. So I never want to sit here and fearmonger someone out of a GLP-1 necessarily. That's not the aim. But I do want to say, hey, your overall health isn't just a weight number and a body size. So what are your health goals? What are you hoping to achieve from this? What are the negative impacts? And can you think about how that would play out with these negative impacts that are likely? You might have constipation and slowed gut motility because that's exactly how the GLP-1 works, is to slow gut movement. What will that do? How well do you tolerate the nausea? Is there a way to titrate the dose down so that maybe you feel a little more of a reduction in your fear of being out of control because now you have an external support with you? And not to say that it's placebo effect, but let's be real, that does people when they are trying to relearn something completely different, to just have some way of quieting the noise they have around themselves. Everyone says it's food noise, but food noise is honestly still probably created by diet culture and this constant feeling of low self worth and failure by not being able to, quote unquote, have that healthy body and ideal physical appearance. I actually made a 5-day email course just about this because I just have it. Well, it's not just me. This is not just a unique idea I have, but in the eating disorder world, we just see food noise very differently. We see food noise as hunger. It has been the hunger cue misconstrued into a different narrative. And so, how do you reduce food noise? You start again by behaviors, feeding yourself consistently and having micro and macronutrition met daily, weekly, on average. The body likes to work on trends, not day to day changes. So, really, are you doing this whole behavior change and sustaining it for 3 to 6 months? If so, I think from that alone, I know people would feel completely different if they just give it that time. But instead, there's also so much fear and immediate gratification needs. And, but what about right now? I'm unhappy now. It's again very complicated. So to the person already on a GLP-1, it's just a matter of knowing you don't have to increase your dose every time your provider says, "Oh, you've been on this dose for 4 weeks, time to go up." We'll ask why. Well, what are you following a protocol? Are you following a protocol from the drug manufacturer? That's another thing to ask about. Versus if you're already feeling like you've had the improvement you're seeking, you don't need to go up on the dose. And then also remembering you don't want to be chasing the weight loss on the scale as your only metric for success on being on it. Being much more conservative if you're looking to not have your adaptive physiology activate is key. The body doesn't like big changes, period, for anything. So if someone is pursuing a weight loss journey, just make sure you're doing it in a way that doesn't hurt your body, is the only thing I can say. But ultimately, I can't recommend intentional weight loss to anybody. It just feels too risky. And again, not necessarily what's ideal for someone's health and well-being, truly.
So I want to make sure I'm hearing you correctly too. So if someone is obese and let's say their A1C is getting close to diabetes, their blood pressure is trending up, we're looking at if something doesn't change, I can foresee we're going to have 4 new medications in the next 3 years because that's a common scenario we see with the patient. So that patient, and we know, let's say if they could lose significant weight from a healthy manner. I mean, really, it comes down to those behaviors again. If they can start eating for nutrition purposes, moving their body, sleeping, taking care of their mental health, all the values of lifestyle medicine, then we could probably avoid a lot of those things. But I'm kind of hearing you say we shouldn't say it as lose weight to avoid those things. Just maybe just say you need to start some healthy behaviors. Is that kind of what I'm hearing?
Well, here's the thing. What does obese mean? Are we looking at a BMI calculation alone? And also, do we understand the ranges of it? Because actually, overweight individuals by the BMI standards actually live longer, which is the interesting paradox. I think it's not, again, not what I think. What I've been told and talked about is that makes sense from an anthropological perspective. You have more reserves on your body when your body is breaking down, so you can sustain supporting yourself longer in that last part of life. In that scenario, I'm imagining the person you're thinking of in this scenario is physically fat. By that mechanism, it's still following the old data of it's because of that body size that they have these medical issues. When I'm actually saying it may not have anything to do with the body size trending up that caused those issues. It's a lot more complicated than that. And if anything, why is the weight trending up? What caused weight to increase in a way that seemed normal? Yes, we're all supposed to gain 5 to 10 pounds every decade of life. That's normal human physiology. But if it's exceeding that rate, why? And, what is about this family or this individual's family history needs to be considered. Is the whole family, genetically larger? I find it interesting to go off on a side tangent here. We know that connective tissue disorders exist, where you've got hyperproliferation of collagen, cartilage, bone, et cetera, but we don't look at fat. And we know the term lipedema, but the only solution to it is liposuction versus why is fat over proliferating perhaps in that individual. Someone who has obesity by weight and BMI calculation alone, what is their body composition? What is their bone density, muscularity, et cetera? There's just a lot more nuance there. And I know you're not thinking of the bodybuilder coming into your office and then having the same question. So I do get that. I think ultimately, someone in that size body, it truly, it's hard to not give this example, but to some degree, it's kind of like Fat Bastard in Austin Powers. I eat because I'm unhappy and I'm unhappy because I eat. I'm oversimplifying it. But that individual already has been told you should feel bad about yourself, period. And if they got better emotional support, you know, which is a privilege for a lot of people to be able to access mental health care, I can't, ignore that enough. It would be completely different if they start healing their stress. Their cortisol levels will come down. And honestly, I would say the high cortisol level is likely what's leading to that excessive weight gain and all the health complications you're talking about, stressing out the pancreas, making the body have more insulin resistance, affecting the blood pressure. I mean, hello, cortisol always increases blood pressure and heart rate. We just never had that included in our metrics for what to do when someone's showing up with hypertension or pre-diabetes, hemoglobin A1C levels. So I think that's really my bigger question is rather than changing how we tell someone to make weight changes or healthy changes in their life, it's more of can we think broader? Could their weight gain be a symptom of something else? And if so, weight loss couldn't be necessarily the answer to it. It's changing other parts of the system, and weight loss will follow naturally if it is at an inappropriate point for that person. Does that make sense?
Yeah. I mean, I think that's what
We ta-
we talk
we
about
talk about
this.
this all the time. So you're speaking our language. We're just making sure our listeners
Yeah, because I think like what
understand.
Sarah and I'd like to say, and we've said this before, we've had multiple guests on the show that have said this before too. If you can think about what you're eating as a way to treat certain things, like eating fruits and vegetables is going to help your heart and your vascular system, and it's many other,
And your poop.
and your poop and your gut microbiome and everything else in your brain. And moving your body is going to help your vascular system and your brain and your musculoskeletal system and all these things. And if I guess if we can think about it like that, so then again, you're just developing healthy behaviors, which are helping all of these systems in your body. And eventually, a side effect of that is weight loss, those healthy behaviors and managing stress and things as a way to treat your heart, your brain, all these other things. Then we're getting there without dwelling on it as lose weight to help your heart and brain.
Right.
And so really
And
we
if
need to
anything,
think how we phrase it.
mhm,
We all need a rebranding in the medical field, I guess.
we all do. We do. We need to unlearn and relearn. And the other thing too is the weight loss that is anticipated isn't some dramatic change in appearance. That's not the goal here. It is simply more of allowing the body to biologically reset itself to a different homeostasis, if it chooses to do so. And again, adaptive physiology being what it was, there's a lot of indication to show an average person will experience that. But we're also not out here in healthcare just trying to change fat bodies. Fat bodies can also exist with perfect labs
Mhm.
and perfect heart rate, blood pressure rates. Again, we don't need to talk about lifestyle changes if the person already abides by that. They just are a fat person, and that is okay too. Better than okay. That's their body. And so I think there's so much nuance still. There's the assumption that fat body will be unhealthy when there's plenty of data to show fat body totally healthy on their own already. And so to your question, yeah, it's about asking more of is this person appropriately living their life as they need to want to in a way that optimizes things without overly asserting the value of health on them, overly making it's your personal choice and responsibility to be in charge of your health. Sometimes people just get bad, cards dealt their way. It just comes with genetics, truly. It's again peeling back all of those layers of nuance to be with that person in that appointment.
I think it's hard for the patient to if there is a patient that is overweight or obese and they don't want to be, and then we're telling them, but you're
Question is
healthy
why? But
and you're
why?
doing things right and your A1C is good and your blood pressure is good. Then it's almost like then they could feel bad for not wanting to be the way the way they are. I'm just
Well,
thinking
again,
of
that's
the
where
flip side too,
the
and then
weight
that's
stigma.
hard for them too.
That's where why do they want to be thinner? Because of what they're taught, because of discrimination, because of how bad other people make them feel about themselves. How much their worth is tied into being more socially appealing and acceptable. I mean, it's so unfair, but also so real. And that's where, again, autonomy and agency exists. And if they are going to pursue it, they need to do it in a supervised way, in a protective way to really watch for those small changes that might show that they're creeping into eating disorder territory. Just because they can do it doesn't mean they should do it.
Because with
I think it's
more
tough
GLP-1s, I feel like society is probably gonna become even less accepting of overweight.
because it's overly simplified. Yeah. I mean, It's wild how many things are put into a black and white dichotomous perspective across, again, public health, population health, and becomes the new norm.
Yeah, you're giving me some
And
new perspectives on things.
I'm soaking every little bit of this up.
I know.
I know we had kind of talked about, not kind of, we had talked about binge eating. We've talked a little about anorexia. What about specifically bulimia? Do we see that more often now? Is that something that we don't see as more commonly now because of GLP-1 access? Where is
It's so
that
interesting.
diagnosis?
So it's so interesting you bring that up because I feel like in the 1990s, early 2000s, bulimia was on the rise. Interestingly, just looking at, our 300 patients, bulimia is not a high prevalence right now. It's interesting when you actually dig in more, it does still feel more like atypical anorexia with binge purge features than it is bulimia by itself. The bulimia specifically, what makes it different, yes, historically was they're normal weighted usually, but it is a compensatory response to eating. And, that means it could be intentional vomiting, it could be intentional laxative overuse or abuse, excessive exercise. There are multiple versions of compensating for eating, and it has to be tied to every single time someone eats. So, yes, someone who does intentional vomiting, it might be an actual binge of eating, but a bulimic individual doesn't have to overeat necessarily as their only mode. They could be eating normally, but still after every meal find some way to compensate. So, if anything, it's not that it's gone. I think it's more fluid in the world of the diagnostic labels. I think individuals, especially with lifelong eating disorders, they even say, add back and forth between, restriction as being my one and only mechanism for weight loss. Then other times I wasn't losing weight, but I was still wanting it desperately. But I was more bulimic then because, again, my weight wasn't dropping and I was eating, but I compensated every time I ate with some my behavior. It's not that it's not prevalent. It's just it blurs into other things a little bit more now. Labels are helpful, but labels are not always definitive.
You've already mentioned this, the other diagnosis of orthorexia. Can you
Yes.
explain to our audience? Someone may be out there and they're just like, I'm trying to become healthier. So I do think about it all the time. When do I know that it's a problem? And when do I know that it's just me trying to be proactive in my health? Because it's gray. This is hard.
I love it. An orthorexia isn't a formal diagnosis yet. I hope it'll be in the DSM-6. But really, I mean, it's under the umbrella, I would say, of anorexia and restrictive eating disorders. So it is this over obsession, truly obsessional with the cleanliness and purity of what someone's eating. And what makes it a disorder, more likely is when it's dysfunctional. Again, people avoiding social events because that gets in the way of their gym time and then what they want to eat and prefer to eat. They don't want to order something at that restaurant. That's taking them out of their life. This obsessional need for control and precise calculation of macros and micros and quantities and the timing of everything. Oh my gosh. The obsession with timing of like, I cannot eat past 3 p.m. Okay, who taught you that? Why'd you decide that? It's usually from a wellness influencer, YouTube. There's lots of information out there with talks about intermittent fasting and keto dieting and this elimination of full food groups. That microbiome hates that and leads to lots of issues. Like it's not good for the body. But again, everyone's looking at it as this physical improvement goal. And I have like people really do feel better initially, but not sustained truly. I think what's interesting about orthorexia is most people never find it to be a problem because of that exact reason you named. Culturally, it's everywhere. There are huge $1 million businesses that are profiting from someone buying certain supplements and following certain protocols and being in the groups where we hold everyone accountable together. I mean, you're talking about villages of people with shared perspectives. And so someone's not going to see it as a problem until someone else in their life says, I miss you. I don't see you anymore. You're different. You're not around. You aren't engaged with us at our family meals, or, you didn't even come to the kid's birthday party because that was your gym time instead. Those types of things are when it really shows that it's more of a problem. The philosophy of an orthorexic person is a little harder. It first has to be seen as, what are you missing because of your belief pattern right now? And they need help seeing that insight before they're willing to change things usually.
Yeah, and you said villages. I guess it can be harder because you can end up surrounding yourself with other like-minded people so
Oh my
much.
gosh, echo chambers everywhere.
Yeah. And social media allows that even more than when we were just communicating with those physically around us.
Hmm.
So I imagine that just makes it even harder to
It
recognize, I
really
guess,
does.
for somebody.
Well, and now with social media, it's not just posting pictures with small filters on it. I mean, I forget the term that just came out, but you can completely renovate your appearance, if you will, before you present it on social media and change every physical characteristic. So people don't even know if who they're getting influenced by, if they're real and if their journey is as bona fide as they're claiming it is. I mean, it's hard. We don't want to distrust each other more, but I think as we keep expanding our community access, we do have to sometimes remember, I don't know this person. I am not directly attached to this person, or engaged with this person. This is a parasocial relationship. This is not an actual intimate, authentic relationship. And I think that gets a little twisted. ANET actually came out with the most amazing short film called The Wrestler. And it focuses more on an adolescent girl's experience on social media, but just showing how toxic it can be and is for so many people. It may not lead always to an eating disorder, but certainly lots of reasons why it would. The maladaptive coping strategy to stress, a way to numb out intolerable feelings, a way to change and control things that otherwise feel out of control, to be more socially acceptable, to meet a beauty ideal. It's so much. And I think it's hard even for adults to really parse through that. It's not just kids that need protection on the internet, adults need it too. It's just too easy to have our reward pathways and what sounds familiar to be trustworthy versus, verified and truly looked at with more scrutiny. It's so much seriousness, y'all. I'm sorry. This is like some heavy stuff here. I'm like
No, I
paradigm
like
shifting all over the place.
take a break and just rethink
I'm
or
having to process myself.
We can all do some butterfly taps. It's like, okay, we still want to
um
enjoy our lives. We want to stay connected to our people. Do not just be an anarchist, y'all, and throw out all the systems. It's just know the systems a little better.
I think one of the biggest things you've said today, and it's something I do feel good that we're doing, is we all need to realize we need to come back to our personal relationships. We need to come back to our personal goals. We need to come back to our own personal health and looking at each individual as who they are, because so much of what has gone wrong has been just trying to do the same care for everyone.
yeah.
Yes, this overgeneralization, protocolization, whatever we want to call it.
And so if a takeaway, a big takeaway from all this discussion, that's probably where I would start, is like we just have made everything too generalized and not
Mhm.
giving that personalized touch to each individual with what they need.
Yeah.
And it's caused a lot of problems because of it.
Honestly, I feel like the majority of the patients I work with, half of their journey to recovery is healing from well, experience in the physician's office, in a healthcare system, in an ER, their constant feeling of being dismissed and validated because they were in a larger body instead of being treated for the malady they actually had. I mean, it is wild how many patients, when we really dig in, we do find medical issues that need to be addressed and likely under or explain better the symptoms they had that they were dealing with, but instead weight was always the forefront of the discussion. It's just so interesting seeing just how that healing, though, really does lead to freedom and reconnection and trust for self and trust for other clinicians. Not all clinicians are going to cause harm. And even if they're our clinicians out there thinking, oh, I've never caused harm, we actually can be a little more honest with ourselves. We don't know. We don't know how someone heard our words and took it a different direction. And we can be humbled if someone says, man, I didn't like how you said that to me. Fair. Thank you for that feedback. Like, let me thank you for the opportunity too to maybe re explain or learn from your lived experience on the other side of that conversation. I think then when we get back to the goal of personal health, it also reminds us that we're in a privileged position to have a personal relationship with our patients. We're being granted access to their health journey. And wow, like what an opportunity to really know someone beyond labs, beyond weight numbers. You know what I mean? So I think what I love, I don't get to practice pediatrics every day, but why I love being a pediatrician at my heart and soul is even when I'm working with adults, they're still little children. I can see their inner child in them wanting to heal. And so I feel like we can have that reconciliation in our sessions, and people are getting better because of that. And they're having experiences in life that are more robust and full and rewarding. Their weight hasn't changed. Amazing.
And for our parent listeners that are out there, if you could just give any simple advice, because I do think this is common that there are many parents that worry about this for their kids today. It's like, oh,
Yeah.
I don't want to cause this. I don't want to be the cause of this. What would you tell a parent of how they can best support their children and kind of decrease their risk of having this lifelong battle with food?
Well, if anything, the other complicated component is, we didn't even talk about RFID today, avoidant restrictive food intake disorder. It's not just picky eating, which again happens in so many kids, leading to nutrient deficiencies. But in this, to answer your question, I'm going to keep it on point, not get too ADD myself. It really is a matter of teaching them that their body changes. The body they have in this moment of time is, their 3-year-old body, their 5-year-old body, their 10-year-old body, and help them start feeling comfortable with the fact that, aren't you glad you don't look like a 3-year-old anymore? Think of all the things you can do in this 10-year-old body, you know? And if you're feeling unsatisfied with your body right now, you just got to keep waiting. Your body will keep developing. And if there's something you want to be able to do, let's figure out what you want to do and make it less about their worth being tied to their physicality and physical capacity. Because again, everyone develops their gross motor, fine motor skills on different timelines. We have the Denver developmental scale, so we know that there's like a range of normal. But once we get above, the basic stuff, it's not really watched anymore. Not every kid is going to be a basketball star. Again, they're not going to be tall enough, perhaps. Not every kid is going to be a rock star either. They may not be able to sing or play an instrument, and it's how do you have kids connect with themselves versus what they want to be as their only guidelight in life. And I think knowing that our bodies are meant to change and change is good is so important to start instilling early, because we know the number one fear of our human species is change. People have different degrees of accepting it or not, but really we all hate change on some level, period. If you say you don't hate change, please give me a call, because I'd love to know how you accept all change in your life. But truly, body change is part of that. Body dissatisfaction is taught, but it can be untaught too. And how you talk to your kids about other people's bodies can also help. If you are saying, shh, don't be rude, you're actually teaching them there's something wrong there that I need to know more about. But instead, at least this is what I do with my 4 and 6-year-old, we actually ran into a mother and her daughter in the bathroom of a TJ Maxx the other day, and they both had achondroplasia. And my kids had never seen someone with achondroplasia before. I said, Mommy, why were they so short? And I said, they were born that way. They actually have a condition that makes them short like that. And they said, what? How do they drive a car? I said, there's probably adaptations in the car to help the mommy drive the car. He said, is she always going to be that size? Yeah, absolutely. And I know it's different. I'm a pediatrician. I can, get into this conversation, but I actually want to inspire other parents to say, like, we can talk about this. We can talk about when we notice differences, and we can explain that is actually normal and healthy for them. That's who they are. And just like we would brown hair, blonde hair, curly, straight, dark skin, light skin, we have to do the same thing for body sizes too. My 6 year old even has a kid in her class who he is like a foot and a half taller than everybody. He looks like he is 9 years old. And he does get made fun of for being bigger. Ugh, I mean, he didn't ask to develop early at all. And nor is there anything wrong with his size. Oh, but it starts young, right? And so it's just naming that this is actually something that's possible. Some kids look very similar to their peers. Some kids are ahead, some kids are behind, but they're all perfectly themselves. I feel like that's the better core message when we're trying to instill body acceptance and worse being detached from body instead of totally engrossed in body size and appearance. But you'll have to ask me in like 10, 15 years how my kids are doing. I don't
Yeah,
know.
well, I like that thought, just your body is always changing, and then just connecting more to, what do you want out of life as far as if they need to change a habit or something.
Right. I mean, even we as adults, I mean, I'm sure I know I can raise my hand and say, whoa, there were so many things that I didn't know until I knew it, in experiencing in his life, being a mom and having babies and having your body change and not really knowing exactly how your body would sort out. And it's not the same as someone else, even if they also had a vaginal delivery or a C-section. I had both. Yay. It's so interesting seeing it from the lived experience angle versus the medical professional goal exclusively. And so I think that's where wisdom does come with our own lived experiences too. And reminding our kids that it's okay if you don't fully get it and you don't have the same experience someone else has. It certainly, though, is all acceptable.
If someone is listening today and thinking, I probably need to address some things for myself, where should they go to look for help?
I would say going to the very website is a great first step. We actually have a lot of resources that people can access. So you don't have to start care today. It can just be, I'm curious. I want to learn more. We have blogs. We have a whole YouTube channel too with lots of paradigm shifting information, harm reduction information. So you can browse through that library. But calling us also is a great way. Just consult, ask some questions. What I noticed the most is historically in the eating disorder world, it was always, I'm not sick enough for care. I'm not sick enough for care. Well, we're outpatient. We're actually asking people not to wait until they're sick enough. We want to help you make changes to how you see yourself, eat food now, because there's no better time than now, truly, to finally heal and better understand why do I think the way I think? Why do I feel the way I feel? How do I find food freedom? How do I find less moralization and more self acceptance and just more joy in life, the whole? Or at least acceptance of the nuance and the highs and lows of a human life because we're not always happy. That's not the goal. The goal is not to live your life with only happiness. It's about resilience. It's about knowing you have tools to solve problems or unexpected scenarios that come your way, not to have this perfect, photo life. So, going to our website, submitting a referral if you are a provider out there and think that your patient would benefit from eating disorder informed care is also a great way, or call our number 844-988 very. Yeah, we're just here to try to help as many people as we can, even as a small startup company. Although I guess I can say we're slowly bridging out of that startup world, but we are still small.
I have links to all of those in
Yeah.
our show notes if you're someone listening and want
Well,
to find out more.
this has been very informative, and we appreciate your time and your expertise. And I really feel like our listeners probably learned a lot. All of us have lots of reflection questions to walk away with after this show. So we greatly appreciate that and look forward to our next show.